Grazie. Grazie al...
Thank you very much, Dr. Marangoni, for inviting me here. Before starting, I would like to know if anyone in the public is a vascular surgeon, and who amongst you regularly uses any type of transdermal laser to treat telangiectasias. A brief introduction about telangiectasias, specifying that they're small vessels, 0.1 to 1 millimeter or 0.3 to 1.5 millimeters. They're superficial, easy to see, and their color changes depending on the vessels and the depth that they can be found in. I know that Dr. Kripa has already partially treated this topic, this disease, so I will skip this. This is a well-known picture by Glaucomasi, where you can see all the different strata of the skin, dermis, hypodermis, and the vessels, and I will go back to this to identify them. These are examples that I want to show you. Here you see reticular veins, well visible in the central part. They're bluish and greenish. Any type of telangiectasias, you can see the different diameters and the different colors. Reticular veins are to be found in the hypodermis, and they can be more or less visible depending on the physiological/pathological status. Reticular vessels can be seen with transdermal light, or they can be seen like in the case that we've just checked, when they're more severe. So you see that above the superficial fascia you see the different positionings of the veins. Here you see again the same a picture to identify blue reticular veins. So the first step in order for us to move forward and understand the patient and their condition is the use of bicolor Doppler, so that we can study venous insufficiencies and analyze the definition of venous diseases characterizing this state. Then skin transillumination will help us map the reticular system that can be more or less visible, as I said before. Chronic venous diseases range from C0 to C6, depending on how visible or palpable the veins are. I will concentrate on C1 according to C classification, which is telangiectasia. I will not focus on any other type of disease or condition because they pertain to other types of treatments. So, after solving the insufficiency or hypertension of the proximal venous system, and by that I mean anything that is before the telangiectasia, you can concentrate on dismantling them. I am using dismantling on purpose here because it's a bad word, but you can't really use it with patients who are generally ladies, because ladies want to hear words like cancelling, erasing, making something disappear, whereas we have to use this specific word because we have to erase completely the vessels, walls. I use monofrequency, that is to say one frequency at a time. In my case, in a hospital where I worked, I've used this for 6 years, 808. Actually, I decided to change to dual boost, because having two frequencies create a radical change in terms of results. So the goal is the destruction of the vessel wall, which is indirect. Here you can see it very well. Hemoglobin is hit for the first time with this frequency 532, so it turns into meta-hemoglobin with a temperature of 70 degrees. It's the second input with the different frequencies, 808, 940, or even higher. I am considering only 940 here. There is vaporization of those elements, and the endothelium is destroyed as well. So, a remark on chromophores, which are molecules that get excited due to specific frequencies, and in the human body that's melanin, water, and hemoglobin, and also other skin elements annexed to it, connected to it, because these are things that we have to take into account, and that shall not be forgotten. Frequency 532 nanometers to transform hemoglobin in metahemoglobin, and it has a particular activity onto the melanin, whereas 940 hits blue chromophores, and that's what enables metahemoglobin vaporization. We have already seen a few slides about these Eufoton historic pictures. Dr. Kripa quoted them and showed them to us before. So monofrequency 532 for superficial vessels with thin walls. This is a procedure that really works, even though we only have one frequency, as you said. Maybe, well, if I remember correctly, we were in our outpatients in Piazza Unità with Mr. Francesco Zini, Francesco Marangoni and his team. I really want to thank them, because this is a group, I call them the lads, but they're really professionals that allow for a further evolution of lasers. And we also have some professionals like us testing the machines and giving feedback. So I wanted to show you this picture that we took together. Professor Leonardi and Dr. Lorenzo Tessari, who is not here with us today, but is part of these group. A few words on dual boost. That is to say, the possibility to associate two different laser frequencies, using them together, not necessarily at the same time, to create deeper damage, 30 to 40% more effective, according to our estimates. So how do we set this machine? We select the lower limb part pertaining to phlebology, telangiectasias, that is to say a combination of 532 and 940. Here are the parameters. As far as 532 is concerned, we use around 2 watts with the tone of 30 milliseconds. Why roughly? Because it really depends on the diameter of the vessels to be treated, on the colors and the patient's phototype. The best ones are definitely the very fair ones. When we treat darker phototypes, well, we are risking that the treated areas are bleached, are subject to bleaching. So 25 watt with a T on of 60 to 80 milliseconds for 940. Synchro or delay, what does that even mean? The two impulses that have different lengths and durations can be started together or delayed. In the beginning, we believed that it would be better to start with 532 and pass to 940 afterwards, so that the passage of hemoglobin to hemoglobin would be guaranteed. But we saw that it's actually easier and more effective if we use them together to create a bigger damage. Fluence. With a 1 millimeter spot, in total, it's 262 joules. So it's only rounded figures, you know, so that's roughly the total. It varies a lot if the spot is widened to 1.5 millimeters, so it would be less than half, 116. When do we decide the spot? Depending on the width of the vessels. So these are the standard parameters, and in a second time, as the operator gets more experience, you may change them. You may reduce the spot for other types of veins, 1 millimeter or 0.75, or you can vary the distance of the handpiece to the skin. So the laser is now ready to be used, but how about the patient? What are the requirements? So the dermis should be hair-free. We should have right treatment in terms of keratinolysis, and we should use polarized light. Why is this important? Because when the light hits the skin and hits a hair, in particular when they are dark, we provoke some spots of burning, carbonizing the epidermis. Because the laser is focused there. They don't create a permanent damage, they heal after a few days, but it's an obstacle to the best possible outcome. So hair removal should be an issue to be addressed. Depending on the fact that you're using a razor, cream or wax, here you see the levels at which the hair is broken. It doesn't really come out of the bulb, but still, cream and wax are better because with the razor, the epilation is not complete and this phenomenon may still occur. This is a very long word. It's PHMB. And it's a molecule that I am really fond of. At the hospital, I use it for a number of goals, to cleanse ulcers or wounds, because it's very delicate with no cytotoxic effect. Whereas if we use it to cleanse the dermis, the skin is less glossy. So we can see the spider veins better when we observe them with transillumination. Then we should cool down the skin to reduce the epidermis and the dermis damage. So you see the cryogen below minus 30 degrees. I would not say that you can't do without, but it's better if you use it too. One of the reasons why, as I said before, you can broaden the spot is this. You don't always have a cryogenic device available. You can apply some ice cubes onto the skin, hence reducing the skin damage that is hence caused. Polarized light is of paramount importance for you to work on spider veins. Without it, you can't do much. You can't really use this device properly. In this picture, which was taken a while ago, I am using Cyrus. I have been using polarized light for a while now. In some cases, it's even lighter. Two pictures. They don't really describe thoroughly what I've just explained because the difference here is not clearly visible. This short video, I don't know if we also have any comments on that. Here you can see the collaterals and the system. We can't continue if we haven't modified this. What is the limit? We can treat this area, those telangiectasias which are red, and bluish, won't be compromised in terms of treatment performed. This is a patient that I saw a couple of days ago. We didn't have a lot of time. She's a friend of mine that wanted to get rid of those spider veins. This leg can't be touched unless we address circular blood circulation insufficiency first. So we can only treat minor vessels in which the reflux can be treated. So you can use dual boost here. So this is the video. Here you see 5:32. We can be very quick. I was wearing glasses and the patient was wearing glasses too. I said something. I said it's very quick in the video. You can see that the spots are close to one another because I reduced the breaks so that I could treat a longer area in a more rapid way, more rapidly. So this is a picture. I don't know if you can see properly. So that's the same patient. I treated the central area of the leg and you can see that it has fully recovered. This is another video by Dr. Zini. You can see the effect of the device. So this is what happens with treatment. So the spider veins are completely erased. The patients are given goggles, as I said before, and they look at it and they say, wow, it's really like an eraser. So those two pictures depict the aspect of the patient after the treatment, immediately after, and this is after 2 days. So immediate post, you can see the histaminergic or skin reaction, and then you can also see something highly interesting in this other picture, a little bit of crusting, and this is the exact way they should look like. They are stable crusts with no inflammatory aspects. Over time, we standardize the time frames and the dosages, and sometimes, whilst doing that, we would see an inflammatory reaction that would stay a little bit longer, hence creating matting, which is what we're going to talk about in a minute. hence adjusting the parameters and standardizing them so that they can fit all operators. This is the result that you see after 2 days. So a little crust. They disappear totally after a month. Some side effects. Matting, that is new subtle red spider veins that follow secondary neoangiogenesis, phlebitis or scarring, generally around surgical scarring. You see those little red spider veins that you can get rid of, 532 if there's more, or dual boost for a better results if they're bigger. Bleaching is not exactly the right term here. Whitening, we generally use it in the dental field, but in this case it happens because we use the component of 532 in an excessive way. So session timings. Generally, when you can work on telangiectasia and reticular veins at a superficial level, the timing is a moment in which there is no photoexposition and not excessive heating. They don't have to do any sports. They have to wear compression stockings, absolutely no steam baths or saunas. Why is it so? Because otherwise the cutaneous circulation is activated, and it's exactly the opposite of what we're trying to do. We've just closed some vessels, and if the post-op indications are not followed, some vessels, especially the bigger ones, can reopen. Session timings, which is a relative one, which is to say the time lapse between the treatment of the same area, at least 1 month. If a patient wants to treat the whole lower limb, I see them on a weekly basis or every 2 weeks. We treat a first leg and then the other one, or different areas of the same leg. A few words on the costs. Costs are the price of single-use fibers plus my hourly rate, depending on how much time a patient will take up. In my area, it's 500 euros per hour, so 250 if a patient stays for half an hour. Fiber costs, well, it's paid over time. You pay it straight away at the first session, but it's single use, so it will be just used for that specific patient. Thank you very much.